I actually want to start with a little disclosure information. When we have our gastroenterology conferences, medical meetings in general, we have these conflict of interest slides where we put up our disclosures, which basically means all the companies that we're being funded by. So I want to say that I don't have any disclosures. I have a pretty strict anti-pharma medical device supplement company rule, and it just allows me to really recommend things without any bias at all. And it's not very difficult to do. Most of these meetings aren't fun to go to anyway. So I don't have any relationships to any of these companies, except that I am on the medical advisory board for the company Microbiome that makes the Smart Gut and the Explora kit, which I think I spent a lot of time criticizing in the second webinar. And that's it. The probiotic that I'll talk a lot about tonight, VSL number 3, I don't have any relationship with the company. I don't own stock. I don't speak on their behalf. In fact, I've never met the representative from the company because we have a pretty strict policy. We don't meet with pharmaceutical or supplement representatives, although she did sneak in once and I met her and she was lovely and we chatted for 2 minutes. So my disclosures are medical advisory for Microbiome, and really a huge thank you to all the patients I've seen over the years. I see about 10 to 20 new patients a week in my practice. At this point, most of them have Sibo. And so, of course, I learned nothing useful about this in medical school. Back in medical school, which for me was 1987 to 1991, the term Sibo didn't exist. Nobody really, I mean, we knew about the microbiome sort of theoretically, but it certainly didn't have the prominence that it has today. So really, I'm so grateful to all my wonderful patients who have shared with us what works, what doesn't, who've allowed us to experiment with them, and who have taught us so much. Okay, so all the mushy stuff is out of the way, and let's get going. We have so many fantastic questions. I think we had 67 questions. A few were repeats, but really most of them were just fantastic, and I am actually going to attempt to get through all of them. So I have just a few introductory slides. The first is just 3 key points I want to make. The first, you're sort of tired of hearing me say this. I'm like a stuck record. Sibo is really imbalance, not overgrowth. So we have this very strict definition of small intestinal bacterial overgrowth and greater than 10 to the third. That's greater than 1,000 for those of you who are not as mathematically inclined, mLs of bacteria per ml in the small intestine, and greater than that equals Sibo. But the truth is it's very fluid, and most of the people who we're seeing, who we're classifying as Sibo, actually have an altered gut microbiome. And that's really how you should be thinking of it. And that's why the breath testing, it's sort of a toss of a coin. It is not something that I really hang my hat on. It's not something that the diagnosis hinges on. The clinical history, the signs and symptoms are quite frankly much more helpful. So again, I want you to frame this in a bigger picture of imbalance in the microbiome and not this strict idea of you have too much bacteria in the small intestine. That's the first point that I keep emphasizing. The second point is that Sibo is a form of dysbiosis. So we're kind of splitting here when we should be lumping, and dysbiosis in the general sense of altered gut bacteria. And the third is that Sibo and irritable bowel syndrome are not the same thing. As I'm fond of telling patients in the office, IBS means somebody didn't work hard enough to figure out what's wrong with your gut. If you slice up the IBS pie, you see many, many things. You see simple things like lactose intolerance or fructose malabsorption. You see undiagnosed Crohn's disease and ulcerative colitis. You see celiac disease. You see gluten intolerance. You see sometimes parasites, the real ones that can actually cause problems. You see Sibo. You see general dysbiosis. You see altered gut motility from diabetes or cystic fibrosis or a medication. You see so many different things. So the idea that we can take all these varied conditions with varied manifestations, varied causes, varied presentations, and we can call it one thing and apply one treatment is really, I think, lumping at its worst. So I just wanted to make those 3 points. And then we're going to get right into the questions because we have about 67 of them to go through. So the first one, and rather than put the number, I've sort of added the topics at the top. The first 3 questions: gas, paleo, and gluten. It sounds like Jared Diamond's book, Guns, Germs, and Steel. So gas, paleo, gluten. The first question: what about uncomfortable gas when eating a plant-based diet, specifically beans and legumes? Is this connected to the activity of gut bacteria? And is there anything that can help with symptoms? And the question was a bit longer. The person said, they soak and do various things, tell people to start slowly. And the first thing that I want to say is that yes and no in terms of activity of gut bacteria. Legumes in general, and also other poorly digestible carbohydrates like cruciferous vegetables, cabbage, Brussels sprouts, etc., have in them one of the main ingredients is something called raffinose. And raffinose is a poorly digestible carbohydrate. And when you hear poorly digestible carbohydrate, you should immediately think, food for gut bacteria. And humans do not have the enzyme alpha-galactosidase that breaks raffinose down into its constituent sugars. So it ends up being fermented in the colon, and it's generally fermented, and the byproducts are methane and hydrogen and carbon dioxide, and you know by now what those gases do. And so that is why these foods tend to cause a lot of gas and bloating and flatulence. And as I like to tell my patients, don't necessarily have cabbage slaw and a kale salad on the first date, but certainly after 10 years of marriage, go for it. And so in terms of what you can do so the question, is it connected to the activity of gut bacteria? It is, in the sense that gut bacteria ferment these substances, but the gas is really because of the raffinose. So what can you do? Number 1, start small, increase your portion gradually. You can add lemon juice. It tends to stimulate the digestive enzymes. Doesn't help tremendously, but can help a little bit. You can soak them overnight, which reduces the raffinose. Avoid canned beans because they tend to have more raffinose in them. You can soak them with a sea vegetable like kombu, which contains alpha-galactosidase and available at most health food stores. You can use something like Beano or Beanzyme if you are vegan, and again, that contains alpha-galactosidase. You could chew on some fennel seeds before or after, make a little fennel tea, which again can help with the processing of the raffinose. But I like to call this good gas because, of course, these foods are plant powerhouses and they contain potent cancer-fighting compounds, phytonutrients, and so on. So I never recommend eliminating them completely. And this follows very well into the second question. Do you believe in any aspects of the paleo diet, like avoiding grains and beans? What about lectins? I think this question was phrased so beautifully because believe in it, it is almost like religion, isn't it? These sort of food beliefs. Are you vegan or paleo or, SCD, or what's your food belief system? So I believe generally in food as medicine, and I don't think there's any right or wrong way to eat. There are some sort of general principles that I try to adhere to and get my patients to adhere to. I don't think that you need to be completely plant-based. I think probably most people can tolerate a little animal protein. There are ethical and other reasons why you might want to do that or not do that. But in terms of the paleo diet specifically, it really is all about the interpretation. So I see patients in the practice who are on a paleo diet who are having bacon and eggs for breakfast and chicken with maybe a few lettuce leaves for lunch and a steak for dinner with some broccoli florets, and they are generally not feeling that well. In addition, if we forget about Sibo and digestive health for a moment, I'll tell you that having spent a lot of time in the operating room as a medical student and resident, when they pull that plug out of the coronary arteries, it's not kale. That's straight up lard. That's animal protein and animal fat. So in addition to thinking about digestive health, you have to think about heart health and sort of central nervous system health and so on, and risk factors for stroke and heart disease and diabetes, etc. So the aspects of the paleo diet that I like are limiting processed carbohydrates, refined sugar, and dairy, which I think in excess are problematic. But I do believe that grains in the form of whole grains and beans, legumes are actually really important for the microbiome. And we'll talk about microbiota accessible carbohydrates in one of the other questions. And I am concerned about the amount of animal protein and fat, not just from the studies that show an increase in bilophilia. If you remember back to Paolo Leonetti's study, with the kids in Burkina Faso and the kids in Italy, and several other studies. The Imperial College Pittsburgh study, where they swapped the African American diet with the South African diet, and they saw a dramatic increase in markers for colon cancer when the rural South Africans who were eating mostly microbiota accessible carbohydrates started eating a sort of high animal protein, high animal fat diet. So we have multiple examples of studies that show the increase in the biophilia and the bile-loving bacteria that are associated with inflammation and obesity, etc. That being said, I think that most people can tolerate some animal protein and animal fat, and I think most people can tolerate some grains and beans. So let's talk about lectins for a moment. Lectins are proteins that can essentially bind to cell membranes, and they're mostly in the seed part of raw legumes and grains, some vegetables, actually some forms of dairy. And we think that lectins exist to help plants defend themselves against pests and insects, and they also help the seeds remain intact as they pass through the digestive tract, not just of animals, but also of humans, so that they can get dispersed later, right? Because plants, like animals, are in the business of reproduction and making sure that their species goes on. And so it helps with that. So lectins are generally resistant to digestion, but remember, they're mostly in the raw forms of these foods. And we're not sure about all the different roles of lectins, but we think they play a role in cell growth and cell death, this sort of programmed cell death or apoptosis. But because they're undigestible for the most part, we can produce antibodies to them. Now, producing antibodies to them is not necessarily a sign that they are bad. We produce antibodies to a lot of things. But there is concern about immune response to lectins, about damage to the gut lining from lectins, and there's a lot that's not known. There's a lot that's hypothesized about lectins. In my practice, I find that most people tolerate these foods very well. And because these foods are high in fiber and poorly digestible fiber, they can really lead to a bump in these beneficial short-chain fatty acids. So my practice is to not restrict them. That being said, if you yourself feel like you don't tolerate them, or you have patients who don't tolerate them, by all means, decrease them. Now, keep in mind that tolerate doesn't mean gas, because they're going to cause gas in most people. So it can be tricky to find out what poor tolerability of lectins really is in terms of symptoms. So it's a little bit complex, and I think that the verdict is not completely in on lectins, but certainly in my practice, most patients tolerate them well. Let's turn for a minute to gluten. Is it that gluten is bad for us, or are we reacting to it because of Sibo? So is the gluten bad, or is our gut bad, and so we can't tolerate gluten? It's hard to believe that something that has been a staple food for centuries can suddenly become bad for us. So the key word there is suddenly. I will tell you that in the first century, so not suddenly, many, many years ago, thousands of years ago, the Greek physician Aretaeus of Cappadocia, and I only remember this because I wrote a long section, a whole chapter about it in my first book, Gutbliss. So Aretaeus of Cappadocia described the condition celiac, and it means abdominal, referring to the abdomen in Greek. It was again very well described in the 1800s by mostly European physicians who described this syndrome of malabsorption and wasting and so on. But nobody knew what caused it. They just knew it was a form of abdominal distress. Around the time of World War II, there was an incredible shortage of bread in Western Europe, and the death rate in children who had been diagnosed with celiac disease plummeted from 30 to 40%. So almost half of the kids with celiac disease were dying to zero when they stopped eating bread, which is at the time, I mean, they weren't eating pasta. So that was really the only source of gluten. So that was sort of the event that caused people to realize that, oh, gluten is primarily in bread. And as you know, gluten is in wheat, rye, and barley. And in the US, high-yield dwarf wheat constitutes virtually 100% of the wheat we consume. And in fact, somebody won the Nobel Peace Prize in 1970. That name I don't recall, but for this sort of genetic tinkering with the wheat, not specifically genetic modification, because it's hybridization and crossbreeding, so not what we typically think of genetic modification, but a form of it, a slower form of it, that led to this product, this high-yield dwarf wheat, that has this incredibly high glycemic index. So most bread that you eat will release more glucose into your bloodstream than table sugar. So it's a very different substance. So what our forefathers ate, number one, they ate a lot less of it. Gluten is cheap. It's a filler. If you are in a supermarket and they have prepared food and you'll see they're selling a turkey burger, often there'll be a little flag saying contains soy, wheat, etc. These are cheap foods. These are fillers, and they're in everything. They're in sauces, they're in meats, they're in lots of stuff. They're in some dairy products. So number one, we are eating a modified form of wheat, not what our forefathers ate. Number two, we are eating a lot more of it. And number three, it is in many, many products. So we have much more exposure to it, and it's a different kind of substance. Alessio Fasano, who is Italian originally, and Italians have done a lot of the great celiac research, but he's been in the US for a long time. He's a pediatric gastroenterologist. He's described this cascade of events where gliadin, which is really the main protein in gluten we're talking about, increases something called zonulin. And zonulin leads to essentially loosening up of the tight junctions between cells. It leads to an increase in intestinal permeability. And Al Fasano maintains that nobody should be eating gluten, that it's bad for all of us. So there was an experiment that was done by his group, and it was an ex vivo experiment, meaning they took essentially human tissue out of the body. They took duodenal biopsies. As you all know, the duodenum is a part of the small intestine, the upper part of the small intestine where we see the classic changes of celiac disease, a flattening of the villi and an increase in intraepithelial lymphocytes. So they took duodenal biopsies in celiac patients, in non-celiac gluten-sensitive patients, and controls. And I think there was a fourth group. And all the groups showed an increase in intestinal permeability. So he maintains that, again, it's a frankenfood. The small intestine doesn't know what to do with it. Nobody should be eating it. And, you know, we think this began literally thousands of years ago when we shifted from being nomadic hunter-gatherers to domesticating crops. And our small intestine, our sort of, you know, Darwinian evolutionary process didn't have time to catch up with that in terms of figuring out how to handle this food. So I think the issue of celiac disease is very complex. The rates now in the US are almost 1%, and it may be higher. It's still a bit underdiagnosed. But I think that one can make some parallels between gluten and celiac disease and gluten sensitivity and sugar and diabetes and glucose intolerance. So like sugar, we eat a tremendous amount of wheat. In fact, like sugar, we eat our body weight. We eat more than our body weight in sugar every year, which is certainly not what our forefathers and foremothers ate. I mean, sugar was this incredible sort of treat and commodity, and, you know, you got a lump of sugar, and that might be what you had for the week. So contrast that with eating more than our body weight in sugar every year. We eat a more refined form of wheat, just like we eat a more refined form of sugar. And so, again, our forefathers ate sugar, and they weren't all diabetic, but it's a different process in terms of the modification and the amount we're eating, etc. So I think it was a great question. Again, people who have Sibo probably react more to gluten because they have more damage to the intestinal lining generally, and the permeability is increased. What was interesting is that in that study, in Fasano's study, people with celiac disease who had active celiac disease that was not under good control reacted much more than people who had celiac disease in remission. So even with the understanding that gluten might be a frankenfood and it might be damaging the intestinal lining or increasing the permeability in all of us, people who have an active gut process like Sibo or celiac disease might be having more damage. The next three questions are on my least favorite topic, but probably the one that I end up discussing the most, which is FODMAPs, the FODMAPs diet. Fodmap, for those of you who, I'm sure it's the number 0, who are unfamiliar with the term, stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. And gosh, where do I start with Fodmaps? In the 1970s, I think somewhere around 1978, some researchers in Australia were looking at elimination diets for the treatment of various things, including urticaria, hives. And so they put people on the strict elimination diet for a few weeks and then did these dietary challenges. And they restricted the common allergens, eggs, fish, nuts, peas, beans, things that people would more commonly react to, seafood. And what they found is that there were certain foods that people reacted to. The first paper, when we sort of fast forward to the gut, the first paper really describing use of the Fodmaps diet was only published about, well, less than 15 years ago, I believe in 2005. And this was a research trial of a low Fodmaps diet in managing GI symptoms. And it was a retrospective study. So they were looking back at people with irritable bowel syndrome and other forms of fructose malabsorption, lactose malabsorption on a low fructose diet. And they found when they queried these people that there was a tremendous amount of improvement, 74% symptomatic improvement in people who limited these high Fodmaps foods. Now again, this is a retrospective study. So they're taking a group of people and they're asking them, looking back at your diet when you eliminated these foods, did you feel better? So it's not really a study that proves cause and effect, but we know that these poorly absorbed short-chain carbohydrates, these oligosaccharides, disaccharides, monosaccharides, and polyols, these poorly absorbed sugars, they can play a role in IBS symptoms because irritable bowel syndrome, remember the hallmark of irritable bowel syndrome is this concept of visceral hypersensitivity, which basically means when we distend the GI tract with air, with liquid, with food, with hydrogen and methane, people with irritable bowel syndrome have discomfort at a much lower level of distension. The classic experiment was blowing up a balloon in the rectum, not something that most people are going to volunteer to have done, but blowing up a balloon in the rectum, and an IBS patient would feel that rectal distension with the balloon at a much lower volume of balloon inflation than somebody without IBS. So that's sort of the classic definition, but it's a little bit of an outdated definition. And of course, within IBS, you can either have IBS-C, IBS with constipation, IBS-D, IBS with diarrhea, or a mixed picture of alternators of diarrhea and constipation. But again, we're lumping, right? We're calling dozens of different things IBS. Nonetheless, if you think again of people who are very sensitive to distension of the intestines with air, with food, etc., and you take out fermentable foods that typically get fermented and produce a lot of gas and methane and hydrogen, it makes sense, right, that those people would feel better when you took that stuff out. It doesn't mean that that's necessarily what's causing the IBS, but since IBS tends to be exacerbated by distension of the gut, and particularly the small intestine, which is a more narrow caliber than the colon, where distension is less well tolerated in everyone, it makes sense that people would get symptomatic relief. What I want you to remember is that this diet was a diagnostic diet for irritable bowel syndrome. The way this diet was really conceived was, if you have somebody with IBS, get them to take out these foods, and if they start to feel better, they probably have IBS. It was not a therapeutic diet, and it is not a therapeutic diet. It was not then, still not today. And the problem is, it's the second question, low Fodmaps diet removes a lot of foods that feed microbes. Yes. What do you suggest for people that have been on a low Fodmap diet for a long time and are concerned about recurrence of symptoms if they stop? So there's no question for a lot of people, taking out these fermentable foods will help them feel better, but the problem is we want to look at the big picture for Sibo. We want people to eat in a way that is ideally going to result in changes in their microbial ecosystem, changes for the better, right? Increase in Faecalibacterium prosnitziae, etc., increase in some of these sort of more advantageous, more beneficial species, decrease in some of the adherent invasive E. coli and yeast species, and so on. And removing these fermentable foods is typically not going to accomplish that. So in the short term, you have less distension of the gut and you feel better, but in the long term, it does not really fix the problem. And, it can, so for example, in IBS patients on a low FODMAPs diet, their hydrogen breath testing results tend to improve, but their microbial analysis tends to, which again, that's sort of hard to judge because on an individual basis, we can't necessarily make a lot of inferences, but large scale, when we look at things that we know are markers of a healthier microbiome, like diversity of species and so on, and abundance, we're not seeing the improvements we want, and we're not seeing an increase in short-chain fatty acids because we're actually decreasing a lot of the substrate materials for that. So, this can be very tricky. Now, some of the things, taking out the polyols, the sorbitol and the mannitol, that's a good idea. These are mostly used as artificial sweeteners and diabetic candy and things like that, and these are foods that we really shouldn't be eating. So some of the foods on the low FODMAPs diet are great to take out, the gluten and the sorbitol, but some of the foods are not a good idea to take out because, again, they're the high fiber foods that we need to affect change in the microbiome. So the first question, what are your thoughts on the low FODMAPs diet for Sibo? I feel like I get to be Santa Claus, good cop in my office when people, almost everyone I see at some point has been told they should be on low FODMAPs or has tried low FODMAPs, and they're in agony and they're so sort of just upset about being on this incredibly restrictive diet. So when I tell them the first thing I want you to do is forget about low FODMAPs, they're generally extremely happy. And it's not a diet that I have found to be useful for treating Sibo. So that is how I would sum it up. And the third question, all my Sibo training says no to fermentable foods. You're advocating increasing max. Won't this increase Sibo symptoms? And I think I answered that. Yes, generally in the short term, but in the long term, the idea is that you are improving things in a way that there's going to be less distress and less Sibo symptoms. So I hope I covered FODMAPs. The next question is four questions on food additives, grains, a ketogenic diet, and dairy. I tried to sort of group them together, but this one is a little bit of a hodgepodge. So what about guar gum, carrageenan, and other additives? I think I just heard a noise. Leslie Ann, everything okay? I think so. I'm going to keep going. Okay. These additives are a really bad idea in a nutshell. Let's talk about carrageenan because that's the one most people are familiar with. Carrageenan can induce colitis in animal models. Now, colitis, a form of inflammatory bowel disease, is a complex disease, right? It's a combination of genetics, immune system, environmental factors like diet. And so I'm not suggesting in any way that carrageenan is a cause of ulcerative colitis, but in animal models, we can actually induce the features of inflammation that looks very much like native inflammatory bowel disease. And carrageenan has been associated with changes in the microbiome. It can disrupt the epithelial barrier. And the epithelial barrier is very important. You don't want leaky gut. So it's not the sole factor, but in several studies, it's been shown to trigger or magnify this inflammatory response in the colon. And if we look at the increase in use of food additives like guar gum and CMC, carboxymethylcellulose, and carrageenan, and the increase in sort of GMO foods and these factory foods in general, we do see an increase in all these GI disorders and colitis and IBS and all of these things. So, of course, it doesn't prove cause and effect, but I think there's some good animal model studies out there showing that carrageenan and some of these other substances can exacerbate colitis and other GI problems. So, and we know they have effects on the microbiome, so I generally recommend that you avoid carrageenan. The next question, why are certain grains beneficial and others not? For example, why is brown rice better for the microbiome than whole rye? I try to avoid creating a very rigid food hierarchy, and the real issue with rye is really that it's a glutinous grain. If we look at fiber content, rye actually has a lot more fiber in it than brown rice. I think a serving of brown rice is about 0.5 grams, of fiber. And I think a serving of rye is about 2.5 grams of fiber, maybe 2 grams of fiber. So from point of view of just fiber, I mean, rye can be a fantastic food, but the problem again, gluten, gliadin, zonulin, epithelial tight junctions between cells is the main issue there. The next question, can a ketogenic diet worsen Sibo? It's interesting when you sort of Google ketogenic diet, you come up with all kinds of things, and mostly things that sound amazing, like, oh, a ketogenic diet can starve misplaced bacteria and yeast. And there is no question a ketogenic diet can be helpful for particular medical conditions. It can help control seizures in people with epilepsy. It has been used successfully in some forms of autism. But for Sibo, it is not a good idea. There was a 12-week study. Again, this is an animal study in mice. And in the 12 weeks when the mice were on a ketogenic diet, they remained lean. They had a normal glucose and insulin levels, all good. But in the long term, they developed lots of fat in the liver, and they ultimately developed glucose intolerance. So this is not something for the long term in mice or men or women. And in another study that was just from about a year and a half ago, a ketogenic diet actually had an antimicrobial effect in mice that led to decreased bacterial abundance and diversity, and decreases in short-chain fatty acids. I think the biggest thing also is that when you're on a ketogenic diet, your carbohydrate intake is severely limited. So where are the MACs on a ketogenic diet? They're not there. The next question is about dairy from someone. And I apologize, some of these topics I could talk for a very long time on them, but again, we have a lot of questions, and so I'm trying to cover things a little more broadly, and I apologize that prevents me from sort of going too deep on some of these, and apologies for that in advance. This next question, we haven't eliminated dairy completely due to calcium concerns, but we stick to unsweetened Greek yogurt, which is low in lactose. How do you ensure adequate calcium intake when eliminating dairy from diet? This question is sort of like the question that I think plant-based people get of what about protein if you're just eating plants? So we know that actually the calcium from green leafy vegetables and from things like kale and broccoli is absorbed better than the calcium in milk. And in fact, half a cup of cooked greens has about the same amount of calcium as 1 glass of milk, so it's almost double. And the green leafy vegetables also have vitamin K, which is important for bone health. It is, again, dairy is a great food for baby cows and other animals, just like human breast milk is a great food for human babies. So there are actually studies, too, that show potentially increased rates of osteoporosis in people who consume a lot of dairy, the idea that the minerals are sort of leached from the bones. So again, this can become like a religious discussion to have dairy or not to have dairy. At the end of the day, I don't think a little bit of unsweetened Greek yogurt every now and again is going to be a problem, but you should not think of this as a health food. You should think of it as a slightly less sweet version of ice cream. Because in terms of health benefits, I don't think that I think there are many other foods that you could be eating that are better for you, where you will be getting the same benefits in terms of calcium. This other question, I just lumped a lot of things in. Dairy versus non-dairy, kefir or kefir, depending on how you pronounce it. Non-dairy, water, kefir, coconut milk kefir would be what I would recommend. The next question, tempeh, miso, natto, all soy-based, yes. But if you're getting good quality, non-genetically modified soy, organic, fermented, the way that they eat it in Asia, where it's not this filler frankenfood that's in everything, particularly for my plant-based patients, it can be okay. I never recommend that people go out and buy soy burgers and soy ice cream and so on. But again, organic, fermented, non-GMO, I don't think that is going to do anything terrible to you. There was another question about trying to find gluten-free crackers that don't have multiple ingredients like corn and added sugar and so on. And, try it. Michael Pollan's good advice. Eat food that your grandmother would have recognized as food. Don't eat food with ingredients that you don't recognize. So if the ingredients are all things that you sort of know about and recognize as food, I think occasional cracker is fine. Maple syrup versus honey, similar glycemic index, fine to use it as a sweetener in moderation. Is it okay to consume bone broth if leaky gut is present? Absolutely. Paleo Whole30 advocates say that whole grains and legumes cause inflammation. Any truth to that? Again, food wars. I think I covered that earlier. What some of these questions show me is that people are really having a difficult time figuring out what to eat, right? Marion Nestle, who's a nutritionist and PhD who I think writes very well about food, has a whole book entitled What to Eat. So there are lots of question marks here, but the thing that I want to tell you and hopefully reassure you with is that there are no sort of indefatigable rules that you must adhere to or else all is lost. That's really not how it works. It is the sum total of what you're eating. And as I tell my patients all the time, if you are eating a lot of plants, a lot of indigestible plant fiber, 6 to 8 servings of healthy, organic, biodynamically grown fruits and vegetables, you can tolerate a little Greek yogurt, a little dark chocolate, a cracker with some other ingredients, some maple syrup. So it is about the sum total. It's not about following these food rules exactly like some sort of mathematical equation. It doesn't work that way. Next question, living dirty. The first question is, again, a very good question. What about AIDS or cancer patients with compromised immune function? And this person, who I think is a practitioner, has some concerns about pre- and probiotics. So there is something called probiotic sepsis, which we can see in people who are immunocompromised, where, again, because the gut epithelial barrier is compromised, bacteria can penetrate, get into the bloodstream, and can act opportunistically. And again, it harkens back to this concept of pathobionts, right? So bacteria that normally would be harmless can now become harmful. And we see this, I see this in the colon a lot in AIDS patients with something called Cmv colitis, where CMV, cytomegalovirus, a virus that many of us are exposed to, doesn't cause any problems, can cause a colitis type picture in the colon, can cause these very angry looking red lesions, areas of inflammation that can bleed and cause terrible diarrhea in AIDS patients. And we can also see CMV in inflammatory bowel disease patients who are on steroids. And we can actually see CMV occasionally in what we call steroid naive patients. So patients who have not been immunocompromised by steroids, but if we check them out thoroughly, would probably have some element of dysbiosis. So it is this idea of systemic bacterial diffusion and inflammation where, because of the compromised barrier in AIDS and chemo patients and cancer patients, bacteria can translocate to more areas of the body than just the gut and cause problems, is a theoretical concern. But at the same time, there are also lots of studies that have been done and ongoing that show that selective probiotics can actually improve the barrier function in these patients, because many of these patients have dysbiosis, and that it can improve something called GALT, G-A-L-T, which is gut-associated lymphoid tissue immunity. So it's a complex question, but my general practice is, in the cancer patients, I always defer to the oncologist, even if I don't always agree with them. And, they're poisoning the patient, but, trying to kill cancer cells and have the patient survive. And that's a complex undertaking. And so introducing a probiotic at that time while somebody's undergoing chemo can be problematic, and we can see these bacteria become more opportunistic and wreak a little bit of havoc that they normally would not. So I generally wait in the cancer patients until they're done with all the chemo, and then I get to work in terms of trying to restore the microbiome. And while they're on chemo, I really focus on dietary therapy. I really focus on the fruits and vegetables and so on, but I tend to not use probiotics, and mostly just because the oncologists go crazy. And in terms of AIDS patients, I think you have similar concerns. What about hand sanitizer in the hospital when hand washing is not always possible before and after every patient? So I don't know if I talked about this in any of the earlier ones, but hand washing with warm water, a little bit of soap, just a regular soap, not antibacterial, rubbing the hands together for about as long as it takes to sing one verse of Happy Birthday, dislodges a lot of the particles, not just bacterial, but viral, in the crevices of the palms that can be transmitted to somebody, and then they touch their face with their hands, it gets into their nose or mouth, they get an infection, they end up with a respiratory tract infection. So that hand washing is really important. It can be difficult when you're going from patient to patient, and because Clostridium difficile is so endemic in hospitals now, it's a real concern. If you're going into or out of a room in a patient who has C. diff, that's generally your general precautions are being taken, where you're gloving up and gowning and sometimes a mask and so on. In just a typical patient room, I do encourage people to try and wash hands. When that's not possible, a non-triclosan hand sanitizer. I have one in my office I use from Amy's Organic, which I really like. It's got cloves, clove oil, and some other essential oils, orange essential oil. It does have a little bit of witch hazel in it, but most importantly, it has no triclosan, endocrine disruptor, microbiome disruptor. The next question was about problematic personal care and household products. That's sort of beyond the scope of the Sibo discussion, but there's lots of literature written. I believe I have a little bit of a section in the book, in the microbiome solution, about that. So you do have to read labels. It's tricky because alcohol is in most of these products, and alcohol is bactericidal. Alcohol kills bacteria. It was our sort of first antimicrobial, or one of the early ones that we used before penicillin, and we use it in the operating room and so on. So when something has a lot of alcohol in it, you have to be a little bit careful. At the same time, you know, if you're cutting up meat on a counter or something and you're concerned about E. coli or with salmonella and other things, you do want to use something that's going to kill bacteria. So I recommend using those things in a more sort of directed way. And for example, maybe having a cutting board that you use for meat and things where you're concerned about infection, that you do kind of clean more carefully. But again, you want to then wash that stuff off before you put food on it that you're going to eat, because you don't want to be ingesting that stuff. Okay. There were several questions about herbal supplements. And I'm going to start with the first one, which is to sort of comment generally on the Mullen study using herbal antimicrobials. This is Gerard Mullen, who is an integrative gastroenterologist at Johns Hopkins. And I have to say, several years ago when I went to Jim Gordon's wonderful course, Food as Medicine, put on by the Center for Mind-Body Medicine, I heard Jerry speak about proton pump inhibitors and their deleterious effects. And it was the first time I had ever heard a gastroenterologist say something negative about these drugs. And it really struck me. And I feel like that course, that Food as Medicine course over 10 years ago, was really pivotal for me as a gastroenterologist in realizing, you know, what we were doing. I have a tremendous amount of respect for Jerry. I have not had the same success with herbal therapy that he has described. The study, I think we summarized it in your packet, but I'll just describe it again quickly. It's a 2014 study. It was a larger group of patients, but it boiled down to these 104 patients who had a positive lactulose breath test for Sibo. They split that group of 104 into 67 who got Rifaximin at the dose of 1,200 milligrams daily for a couple of weeks, and 37 who got herbal therapy, and the herbal protocol is described in your packet, for 4 weeks. So again, 104 patients, positive Sibo test, 67 get Rifaximin, 37 get herbal therapy. And then they test them again with another lactulose breath test, and they find of the Rifaximin group, 34% have a negative test. And of the herbal therapy, 46% have a negative test. So the herbal therapy was actually more successful than the Rifaximin for rendering a negative breath test. You know, it's a complicated problem because breath testing is so imperfect as a marker of Sibo. And, you know, they then took 14 of the Rifaximin non-responders. So of those 67 patients, 34% had a negative test. They took some of the ones with a positive test, 14 of those, and gave them sort of a rescue herbal therapy, and they found that 57% of them then had a negative test. But they also took some of the non-responders and gave them triple antibiotics, and they found 60% of them had a negative test. So, you know, there are lots of ways. I think what the study shows, there are lots of ways to get to a negative lactulose breath test. And a negative lactulose breath test, unfortunately, does not always mean no more Sibo. So I think it is a complicated study to really dissect out. What I will say in terms of side effects is that herbal therapy, one patient had diarrhea and it didn't reach statistical significance. With rifaximin, one patient had an anaphylactic reaction, so serious allergic reaction, 2 patients had hives, 2 patients had diarrhea, and 1 patient had C. diff. So I think what we can clearly say is that herbal therapy from the side effect point of view is much less deleterious. And we're going to get to rifaximin on the next slide. Digestive enzymes with meals. I have never found digestive enzymes to be helpful. That being said, well, 2 things, 2 caveats. The first is that patients who have pancreatic insufficiency, patients who are diabetic, chronic pancreatitis, etc., in some patients with celiac disease that have low enzymatic activity, in specific circumstances, I will sometimes use some amylase or lipase and find it to be helpful. But in general, and in the Sibo population, I personally have not found it to be helpful. Anecdotally, I have had patients who said, when they use their digestive enzymes, they feel better. And when that's the case, I take a look at what they're using and make sure there's not anything objectionable in it. And I tell them, listen, if this works for you, wonderful, keep using it. But I am not in the practice of prescribing digestive enzymes, not because I can tell you definitively they work or don't work, but because I can tell you definitively in my practice, I have not found them to be tremendously helpful. Betaine hydrochloric acid in people who have low acid, which we're going to talk about in one of the questions. Again, in somebody who has not been on a proton pump inhibitor for a long time, where I suspect that they would have achlorhydria, absent acid or low acid, not found it to be particularly helpful. Third question, can you cycle low doses of herbals to prevent relapse? I have not been able to reproduce the results of the Mullen study with herbal therapy, so I generally don't use it, so I can't comment on cycling it. Can supplements like L-Glutamine or DGL, which is essentially licorice, improve intestinal permeability? There is lots of theoretical data about L-Glutamine. It's a non-essential amino acid. When you read about it, it can repair the gut barrier function and is involved in maintenance of the gut barrier function. There are animal studies showing that it can improve intestinal permeability experimentally in animal models. There are studies suggesting that it may improve colitis in patients with ulcerative colitis. That's a little unclear. There are studies looking at high-dose IV glutamine or glutamine-based oral rehydration therapy in patients with diarrhea. I, a few years ago, was in the practice of recommending glutamine and zinc in patients with Sibo and leaky gut, and I stopped because I really did not see a significant improvement. I'm, again, fortunate to have the practice sort of as a lab, and most of these things, I mean, these are not harmful things that we're using on people, but we do have the opportunity to evaluate some of these treatments on a larger scale. And in my experience, which is, again, just one practice, so I'm not suggesting that the verdict is in, again, on this, but in my practice, I have not found glutamine on its own with zinc, with DGL, to be particularly helpful. Now, it may change your intestinal permeability test, but in terms of whether it's actually improving symptoms, that's a different thing. Peppermint oil supplement, what brand? I like Heather's Tummy Tamers. That's typically the one I recommend, but there are lots of them out there. Does enteric-coated peppermint decrease the likelihood of triggering GERD? And again, we're going a little far afield from Sibo, but I wanted to try and answer all the questions. If you look in the textbooks, it will tell you that peppermint can increase the likelihood of the lower esophageal sphincter opening and acid reflux and so on. Most patients who actually have reflux will not describe worsening of symptoms with peppermint. So the rule of thumb is if you have GERD or you're taking care of somebody who has GERD and peppermint, enteric-coated or not, worsens their symptoms, they're probably better off avoiding it. If it helps their symptoms, they can take it. Do you recommend alternative remedies like oregano oil, berberine, garlic? Generally, no. I will sometimes use garlic and a little touch low dose of wormwood tea in people with blastocystis hominis, Entamoeba histolytica that I talked about last time, who are really freaked out about it and insist on some therapy. I will occasionally tell them to do that, but for Sibo, I have not found these things to be helpful. Question on pre and probiotics. Can high doses of probiotics be used to treat infections? They can, but it depends on what kind of infection. So if you think of a vaginal yeast infection, which is really imbalanced, right? That's really missing microbes. You can absolutely improve that with probiotics. You can sort of crowd out the yeast. I don't know that I would be treating a gangrenous leg with probiotics. I think that would be a bad idea, but certainly for these more minor infections, and we have tremendous success treating urinary tract infections and preventing urinary tract infections in women using a combination of D-mannose, which again can prevent E. coli from adhering to the bladder wall, and a probiotic like VSL3. So we have firsthand experience in urinary tract infections and sinus infections in our patients, even though I try not to spend my time treating sinus infections and I try to stick to my zone of the gut. Pure Fem Vaginal Probiotic. I'm glad someone mentioned this. So as you might recall, the most abundant flora in the vaginal vault is lactobacillus. And lactobacillus plays a really important role because it produces acidic substances like hydrogen peroxide that can repel pathogenic bacteria. And in fact, when a woman has healthy high levels of lactobacillus, it can actually kill HIV cells through acid production and other sexually transmitted diseases. So a healthy vaginal flora can actually decrease the likelihood of somebody getting a sexually transmitted disease who's exposed to it. Pure Fem has 3 forms of lactobacillus: acidophilus, which is a main hydrogen peroxide producing form, rhamnosus, and reuteri. And rhamnosus and reuteri both can adhere to the bladder wall, the vaginal wall, the gut wall, and prevent adhesion of things like E. coli. So it could be Pure Fem. That it's not necessarily a brand that I would say you have to go with that brand, but a high lactobacillus probiotic, which you can use. Pure Fem is used topically right into the vagina, which makes sense, but oral probiotics also work for the vagina, and they do enter via rectal seeding. So again, you ingest them orally. There have been studies done to show that they're present in the rectum when they test it, and then from the rectum they ascend, because we're sort of next door neighbors, the vagina and the rectum, and so they get from the rectum into the vagina and go up into the vagina and do their magic. After a course of antibiotics, are fermented and prebiotic foods adequate to repopulate the gut, or is a high colony-forming unit, CFU probiotic, needed? It depends. It depends on what that person's terrain is like. Remember terrain from the first call? So if you have somebody like my perfect storm patient I described, who had not been a good eater, meat and potatoes diet, lots of PPIs, lots of antibiotics for prostatitis, got the norovirus on the cruise ship, fermented and prebiotic foods, we're not going to do it for him. But if you have somebody who's generally been in good health and then has a course of antibiotics and maybe they're just having some antibiotic-associated diarrhea, which is a form of Sibo, they might do fine with some sauerkraut and kimchi and so on, and some high fiber, high inulin foods. So I don't believe that a high CFU probiotic or any probiotic is needed in everyone. Is diarrhea a possible side effect of probiotic use? It is, depending on what the contents of the probiotic are. So it can be because of the bacteria that are being introduced, but it can also be because it's affecting motility of the gut. And now with an increased motility, somebody's had slower transit before where the motility is speeded up, might experience that as diarrhea. And they can also interfere with bile acid conjugation, which we talked about a little bit last time, which can end up causing constipation or diarrhea depending on which way the bile acids are going. XOS, xylo-oligosaccharides as a prebiotic. So xylo-oligosaccharides can potentially do some good things like increase bifido, increase short-chain fatty acids like butyrate and propionate, and increase total numbers of short-chain fatty acids, and decrease lipopolysaccharides, which are sort of associated with infection and inflammation. But most of the studies are small numbers, or they're just experimental. So for example, the study I'm most familiar with, which is a study from about 5 or 6 years ago, where they took 60 healthy volunteers and they supplemented them with just xylo-oligosaccharide, with xylo-oligosaccharide plus inulin, or with placebo. they saw these nice changes with increase in bifido, increase in butyrate, increase in total short-chain fatty acids, decrease in LPS, but we don't know if that actually translates into a clinical effect. And the substance, like a lot of these substances, the food manufacturers love them because xylo-oligosaccharides don't have a lot of side effects and they are easily incorporated into foods. So, I'm always a little wary when the food manufacturers claim that these foods have superhuman powers and they're going to kind of heal everything that ails you. But that being said, it might have some promise as a prebiotic, but I certainly don't have enough experience with it to comment. So some questions about VSL number 3. Can taking VSL, and I for all of these questions, I just put VSL, but it's VSL number 3, make you feel sick? Absolutely. How to avoid. When you have a very sort of disordered and depleted microbiome and you start reintroducing species, you often feel it. People often have bloating, they have more gas production, they don't feel well. Some people have nausea. I would say that the majority of the Sibo patients I see in my practice, when they start VSL, they have some kind of symptom. They feel it. The majority are able to tolerate it and push through, but I tell people, and it's the same instructions, I think we included that in the packet, of decreasing the dose, starting slowly. Sometimes instead of the double strength packet, which is 900 billion, I'll put people on just one capsule of 112.5 billion and go very slowly. So I'm not sure that there's a way to avoid it completely, but certainly cutting the dose down and increasing it slowly is one way to help people manage those symptoms. So question about VSL in enteric coating and correlation with microbiome sequencing results while on a strict diet, and some frustration, I think, with a lack of improvement in terms of test results. So this question raised a lot of good points. The VSL number 3 is not enteric coated. So this was somebody who took the VSL and actually put it in some capsules that would provide an enteric coating to protect it from stomach acid. And they were doing microbiome sequencing and not seeing the results they expected when one considers what the bacterial spectrum, the microbial spectrum of VSL number 3 is. And what I want to say is I wish that that was the level we were at, that we had that kind of scientific specificity to alter the microbiome, but it's really just not there. The sequencing is not there, and the therapy is not there for that kind of targeted, like, this is my number, and it's 0.08%, and I'm going to take this many billion CFUs of this species, and it's going to increase it. Does not work that way. We are so far away from that kind of directed therapy and seeing the results in microbiome sequencing. So what I can say is I'm not surprised at all, and I would probably focus more on symptoms and less on the testing and the percent. So another question about a client with more bowel movements and diarrhea that seemed to have some poorly digested food particles in it after starting VSL, and some worry about possible malabsorption issues. So VSL can cause diarrhea and it can improve diarrhea. We see it improving diarrhea in patients with inflammatory bowel disease, with ulcerative colitis, people who have chemo-induced diarrhea, antibiotic-associated diarrhea, etc. But we can also, again, see it producing diarrhea. And again, it may have to do with a change in the metabolism of bile acids. It may have to do with changes in gut motility. There are other things you can do. There are other markers of malabsorption. So is the person losing weight? Are they, if you look at, is there change in B12 or iron levels or folate levels or carotene, things like that. So is there a decrease in the albumin, which is a protein level in the blood? So seeing poorly digested food particles in the stool is not in and of itself representative of malabsorption. If you are eating a diet that's high in foods, has a lot of foods that are high in cellulose and other poorly absorbed substances, you're going to see a lot of that in the stool, like corn kernels, etc. It can be a transit issue. So poorly digested particles in the stool can be a sign of maldigestion, not necessarily malabsorption. And it can be a sign of rapid transit, or it can be a sign that the diet is high in cellulose-containing foods and other foods like that. So I would look at some of the other markers of weight and nutrient absorption and so on. And remember that often the diarrhea is on a colonic basis of poor absorption of fluid through the colonic lining back into the bloodstream. The main function of the colon is to reabsorb fluid from the gut lumen back into the bloodstream. So if the colon is inflamed for some reason, you can have a looser stool, but the main area where the important nutrients get absorbed is upstream in the small intestine, and not even the part of the small intestine we're typically seeing Sibo, but higher up in the duodenum and jejunum. So that's where typically fat-soluble vitamins like A, D, E, and K, calcium, magnesium, iron are absorbed. The main one that's absorbed in the lower part of the small intestine is B12, and with Sibo, of course, we can see low B12. We can sometimes see low iron. So I would do a little bit of an evaluation there. And of course, you can always try cutting the VSL dose down and restarting it at a lower dose. And the truth is, not everybody responds to VSL. That's the reality. I mean, it's my go-to one, but not everybody responds. And there are clearly patients in our practice who do better off it. I absolutely see that. Do I always use probiotics? Not always. Most of the time, but not always. And again, I'm very receptive to the idea that somebody might not be better with a probiotic. I usually tell people, let's give this about 90 days because it's often not a fast response, and see. And if at the end of 90 days you feel like it's helping, you could continue it, and then we can talk about at what point when you feel like you're really improving, do we start to taper it and see. VSL is expensive and it's inconvenient to take, and it does not taste delicious, the powder at least. And so if there's a way for people to maintain how they're feeling, the improvement that they've had with just diet, that's always preferable to me than continuing to take the VSL. So I am pretty quick to recommend it, but I'm also pretty quick to start tapering it, either because somebody has reached a good level of improvement and I want to see, do they really need it, or what's the minimum they need, or because somebody has not responded and I'm like, if this really doesn't seem to be helping, let's stop it. Do I have concerns about reintroducing more bacteria to the small bowel? I really don't, because again, I think of Sibo much more as missing microbes generally and as a sort of bacteria depleted condition than this idea that there are massive amounts of bacteria in the small intestine. In IBD patients, I'll use a dose anywhere from 1 to 4 packets a day of the double strength. In the non-IBD Sibo patients, I tend to use a lower dose, starting with half a packet and working my way up. I rarely go above 2 packets in the Sibo patients, but again, I can't give you a lot of scientific evidence for. It's more trial and error for why I do that. Is I find that the IBD patients, particularly the colitis patients, respond better to the high dose VSL, and often we are able to keep them in remission with just diet and a higher dose of VSL. And with the Sibo patients, I feel like the diet is much more essential, and the VSL is sort of the supporting act, but there's a little more leeway for lower doses or no doses. Okay, I couldn't avoid it, Rifaximin and other medications. So VSL was Xifaxan with Herbals or alone. I have written 1 Rifaximin prescription in my life, literally 1. It was a woman in her 70s. She had chronic obstructive pulmonary disease, COPD. She'd had part of her lung removed. She'd had literally like 4 bouts of pneumonia a year for 10 years. She'd been on just dozens and dozens and dozens of courses of antibiotics. She had diverticulosis, so she had a lot of stasis of colonic contents. She was on steroids chronically. She was on and off antibiotics chronically. She had diverticulosis and very slow transit through the gut. I mean, everything was just a mess. And she just was not getting better. And even a small amount of fiber really set her off. And I just really was at a loss. And she said, please, 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 let's try it. And I did. And it didn't work very well. She felt great for about 3 weeks. And then, of course, her symptoms came back. So, I see a very skewed population. I see people who have tried this stuff. They've typically seen 1 gastroenterologist, sometimes several. somebody has written them a Rifaximin prescription, often several prescriptions, and they're not better. It's certainly possible. I believe that there are people out there who take a course or two of Rifaximin and get better and go on their way, but that's not the population I see. I see the people who have refractory Sibo, and most of those people are worse after the Rifaximin. They're initially better because the gut is sort of sterilized and they feel well, there's no gas production, but as they get regrowth, it's selective regrowth, and now they've dug a deeper hole and they are typically worse. So we know that Rifaximin does decrease bacterial counts, not just these sort of bad bacteria overgrowing in the small bowel, but overall. And so I really, it's not a drug that I found to be helpful that I use. So I don't use it, not with Herbals or alone, in terms of Xifaxan. Any difference in using Rifaximin, and I apologize, I should have used Rifaximin in the first one, the generic, rather than the brand name. Any difference in using Rifaximin to treat Sibo if IBS also present? Again, I don't use Rifaximin. Can going off the pill help with other GI symptoms like GERD and IBS? GERD, not so sure about. It may, but certainly IBS and certainly IBD, my experience has been that getting off the pill can absolutely help with that. Birth control pill versus intrauterine device in a patient with Sibo. In Sibo patients, I absolutely try and get people off birth control pills, and often people who are on birth control pills with Sibo, they're having frequent yeast infections. We know that it's contributing to changing the hormonal milieu in a way that is potentially exacerbating the Sibo symptoms. So the old-fashioned copper IUD that's non-hormonal is actually the preferred form of birth control. Now, that's not perfect either. That has potential problems in terms of heavy bleeding and so on, heavy menstrual cycles, but from a Sibo point of view, it's preferable. Questions on yeast overgrowth. The first thing I want to say about this is that yeast overgrowth is part and parcel of dysbiosis, of alterations in the microbiome, and when you have missing microbes, you have overgrowth of other species, so yeast become sort of a pathobiont. What do I think about SIFO, small intestinal fungal overgrowth? Do I ever treat with antifungals? We know that about a quarter of patients with unexplained GI symptoms, when we culture them, will have overgrowth of yeast species in the gut, in the small intestine, and we know that from several studies. It's not necessarily a cause and effect, but we know that the things that lead to gut symptoms, whether it's Sibo or other sort of more nonspecific symptoms like antibiotics and steroids and proton pump inhibitors, etc., we know that those are all associated with overgrowth of fungal organisms. And the same things that cause Sibo, proton pump inhibitors, antibiotics, steroids, dysmotility, cause SIFO. And so it's part and parcel of the same thing. It's sort of, the different side of the same coin. And I think of this not as a whole separate thing, but as a form of dysbiosis that we see. And most people with Sibo, if we could accurately culture what's going on, not just in the small intestine, but in the proximal colon, we would find higher than normal levels of fungal organisms. And it's because I draw it out for patients this way. I sort of draw a square and I say, this is your abdomen. And then I just say, for the purposes of discussion, I'm going to draw a line, and this is 25%. It's much exaggerated. The rate of fungal colonization is lower, but I'll say, let's say 25% are fungal organisms and other less helpful species, and 75% are your healthier gut bacteria. And I say, okay, now you've taken a broad spectrum antibiotic for 2 weeks, so you're missing a third of your gut bacteria, and I slice off a third of the 75%. And so what happens is that these organisms now overgrow to take up the room. And so it's not that you have an infection per se, it's that you have imbalance, because these organisms are like, yay, more room for us, we're going to overgrow. And so how do you beat them back? Do you use potent antifungals that potentially can have liver toxicity and that just temporarily suppress them, or do you try and crowd them out? So my preferred way of treating it is by restoring balance to the microbiome. I see people who have been literally on years of antifungals, years, and eating these very restrictive diets, eating a paleo diet with minimal carbohydrates and antifungals, and they're not better. And so it's a path I tend to not go down. That being said, if I do an endoscopy on someone and I see that they have thrush, they have yeast overgrowth in the mouth, not a coated tongue, but actual Candida, or more typically plaques of Candida in the esophagus, what we call Candida esophagitis. In those patients, I will use an antifungal. Or if somebody has a fungal infection on their nails, or a woman with vaginal yeast infection, if there's a lot of yeast overgrowth onto the breast, or an area where I frequently see it, which is in the rectum, if they have that sort of diaper rash yeast overgrowth, I'll use an antifungal either topically or orally with the other for a limited amount of time, typically a week to 10 days, rarely more than 2 weeks, in conjunction with the diet and often a robust probiotic. There's no point giving somebody an antifungal and having them, continue to eat large amounts of sugar and processed carbohydrates and so on, and high glycemic index foods, because it's going to be a temporary fix. So I really believe in treating it in the setting of looking more big picture. And I don't think that you have to be very strict and do these very restrictive anti-yeast diets. I think they work in the short term, people feel fine, but at some point you have to resume a more normal diet, and often the symptoms come back. So if yeast overgrowth is present, I do alter my approach to Sibo if it is actually a form of yeast overgrowth that I can see and touch, like the esophagitis, the Candida in the esophagus, or sort of rectal candidiasis. But there's, again, sort of an assumption that many, if possibly most people with Sibo also have SIFO. So I don't see it as a whole separate thing. Vaginal candidiasis, which do I treat first? I treat both. And we also have great results treating vaginal candidiasis and BV, bacterial vaginosis, which are kind of sister conditions. Both represent a decrease in the native lactobacillus flora and an increase in yeast species, or in the case of bacterial vaginosis, some varied other microbes that are not lactobacillus. And we love treating this. We will often use topical VSL. And you can use a lactobacillus, products like Pure Fem that we talked about, but we often have people make up their own little concoction with a little coconut oil or water, and it works great. So we don't, again, see these as whole separate things. We tend to treat everything together. Is my Sibo diet the same as an anti-Candida diet? Not really, because those anti-Candida diets tend to restrict most grains, if not all, and things like sweet potato and fruits and so on that we would typically want to use for really increasing beneficial gut bacteria. So our diet tends to be less restrictive. If somebody really is just sort of, fungating yeast all over and really yeasty, we will often recommend that they limit grains and so on, but our typical diet is less restrictive. Question about antibiotics, and I apologize, I'm going over a bit. It's 10:16. We'll probably go to about 10:30. It was really impossible to go through all these questions in an hour, so I apologize for those who have to leave the call, but this will be available. Leslie Ann will send the link out in a day or two, so you'll be able to listen to the end of it, to the bitter end, if you like. Question about antibiotics, and I just have 1 or 2 slides to go. What can we do about those well-meaning but ill-informed doctors who continually prescribe repeated rounds of antibiotics in kids for strep, etc.? It's sort of like the approach the pharmaceutical companies took when they went direct to consumers for their marketing. We have to go direct to consumers for our marketing, about our message that these drugs are really a problem. And a well-informed consumer is really the best defense, because it's really difficult to get physicians to change their practice. And there are just so many different factors from, gosh, this is how I was taught in medical school, being unaware of the side effects, being concerned about litigation. Well, what if this surgery I'm doing to remove a kidney stone or take out a tooth or whatever it is, if there's an infection, I don't want to be sued for the infection. I don't care if the person gets C. diff, that's not my problem. So part of it is just a compartmentalization of medical care where everybody's focused just on their little neck of the woods, when we know everybody should be focused on gut health. But most people are not. So there are really 2 reasons we prescribe antibiotics for strep: to prevent 2 complications that are both very rare. One is post-strep glomerulonephritis, which is a form of kidney failure that can actually lead to complete kidney failure, dialysis, kidney transplant, but it's very rare. And the other is rheumatic heart fever, rheumatic heart disease, which is also very rare. So decades ago, the risk of developing one of these two complications was probably a real risk. Nowadays, the risk of developing C. diff and being really sick from that and maybe losing your colon or Sibo or anything else is much greater than the risk of these two conditions. And strep will go away on its own, but it really depends on what the background noise is. And my daughter, who was a C-section baby, only nursed for 5 weeks, almost 20 courses of antibiotics before she was 2, I'm very, very concerned about additional antibiotics with her. And so I tend to not even go and take her to get swabbed and just sort of power through it. But if your child does not have, sort of crazy exposure to lots of antibiotics or a lot of other risk factors, and if they're really sick and you're concerned about a peritonsillar abscess or other kids at home or so on, you may choose to treat. So there's no absolute right or wrong answer to this, and you have to look at each case individually. But I will say, as a parent, if you have a strong sense that my kid has strep, but they're okay, and I'm going to keep them home so they're not out infecting other people's kids, and I'm going to treat them symptomatically with soup and whatever else they need, and they're getting better, I think that's fine. So I don't think, again, there is just one answer for this, but you really have to be a strong advocate. And when they prescribe the antibiotic, I believe in full transparency, say, thank you, I'm going to hold on to this prescription. I'm maybe even going to get it filled, but I'm going to wait and give it some time. And if they're improving, I'm not going to use the antibiotic. But, thank you for providing it in case we need it. In the microbiome solution, I think we included in your packet too, the 10 questions to ask your doctor if you've been prescribed an antibiotic and 10 things to do after you've been prescribed an antibiotic. So hopefully that will provide some additional tips. If you become resistant to a single antibiotic, are you resistant forever? No, that's the good news. You're not always resistant forever. Why? Because the microbiome is always changing, and it's not you that are resistant, it's your microbes that are resistant. So we see this all the time where people have a urinary tract infection and it's E. coli and it's resistant to, Cipro. And then a couple of years later, they have another E. coli infection. Now it's sensitive to Cipro. So it's not always a static thing in terms of antibiotic resistance. Unfortunately, the general direction we're going in is more and more antibiotic resistance in general. So that's the bad news overall, but it doesn't mean for you as an individual that you're always resistant. And it also depends on what kind of infection. So a urinary tract infection with E. coli might be sensitive to Cipro, but a gut E. coli infection with a different form of E. coli might be resistant. So remember, there are multiple different strains for these bacteria. We have a few miscellaneous questions. How can we improve motility in the gut? Role of exercise, sleep, and stress. You heard me say it before, if you're not moving, neither are your bowels. So exercise is super important, from gentle exercise like walking, which stimulates peristalsis, to twisting yoga poses, more extensive cardio. Really depends on preference. It's all good. It's hard to say one is necessarily better than the other. Do what seems to help you the most. The people we see who come in to the emergency room with the fecal impactions are typically nursing home residents who are just lying in bed all day. In addition to getting bed sores and clots in their legs, their guts just stop moving, and they often come in with volvulus and fecal impactions and other really unpleasant gut things because of lack of motility. So exercise is really important. Sleep is important too. So rest, restorative for the gut, that's important. And stress can go either way. It can slow you down, it can speed you up, but in general, we think it's not great for the gut. DMR, duodenal mucosal resurfacing for Sibo. This is just a few seconds about this. It's a technique where it's an endoscopic ablation technique where you do endoscopy, upper endoscopy, and you use heat and catheters to essentially damage the surface of the duodenum, and it heals with scarring. And it's been found in some studies, it's very early stage, to improve glycemic control in diabetes, to improve blood sugar, probably because when you ablate the lining, the duodenal mucosa, now the nutrient absorption is different. So it's sort of an experimental treatment for diabetes, and I am not aware of any really compelling studies showing that this could help Sibo. Effects of Botox and other dermatology products on the gut. Can damage from lasers cause inflammation in the gut? We actually have a lot of experience with Botox in the gut because it's one of our early therapies for a condition called achalasia, where the lower esophageal sphincter is essentially tight and doesn't open. And so people, when they eat, the food doesn't go from the esophagus into the stomach. It all piles up in the esophagus and eventually they vomit. It's a really terrible disorder. It's a connective tissue autoimmune disorder. And when we inject Botox into the sphincter with our endoscopes, it relaxes the sphincter, just like it relaxes the facial muscles when people inject it into the face. And that allows people to swallow. It wears off after a while, just like it wears off in other parts of the body when it's used cosmetically. But that's an example of a indication, like the main indication, sort of FDA-approved indication for Botox is for spasticity, injecting it into areas where people have problems with spasticity, often people who have cerebral palsy and other conditions. The cosmetic use, which is by far the greater use, is all off-label. And the GI use is actually off-label too. But we know it works well there, relaxes the sphincter, and people can swallow. Eventually wears off. You typically have to do it a couple times a year. I'm not aware of a study looking at the effects of Botox in the gut for achalasia, but keep in mind we're injecting the lower esophageal sphincter, which is pretty high up above the stomach in an area where this is one of the least densely populated areas in terms of gut bacteria. If you were injecting it elsewhere in the gut where it would affect motility, it would typically paralyze things. It would typically slow down motility, decrease peristalsis, and that would not be a good thing. That would be something that would contribute to SIBO. So I just don't know of any studies looking at when you inject Botox into the face, what's the absorption of that into the body that could affect motility. That would really be the question. And the answer to that is I don't know, but I'm with you on concern with all these lasers. And you know, when I tell people when you're using these lasers, you're removing the superficial layers of skin. The superficial layers are there to protect you. And yes, they can get sunspots and show signs of aging, but they're there to protect the skin underneath. And so when you peel that all off, of course, you have an increased sensitivity to sun, and you can have accelerated aging because now that surface protective layer is gone. But I really don't have enough familiarity with these different derm techniques or familiarity with the literature to give you much more information than that. Atrantil, I do have a lot of information on because when it first came out, we used it a lot in our practice with unfortunately very disappointing results. It's technically a botanical. It's one of these sort of more natural remedies that is supposed to decrease abdominal bloating and discomfort. And you know, whenever you see a product that claims to do like 6 things, so it's supposed to decrease abdominal bloating and discomfort and dyspepsia and reflux and Sibo and so many things, you have to wonder. It's not harmful, I don't think. It has not been in my experience. We've used it in about 50 or 60 patients, and it's helpful literally in a handful, in 2 or 3. It's peppermint leaf and tree bark and horse chestnut extract and a couple other things. And it's, again, supposed to decrease the methane-producing bacteria and do a couple other things from this, you know, polyphenol ingredient. But we have not found it to be super helpful. There is something, Iberogast, which is a compilation of different medicinal herbs that we will often use in Sibo. The recommended dose, I believe, is 20 drops at a time. We use 10 because the 20 can cause some abdominal pain. And we haven't found Iberogast to be super helpful in terms of fixing Sibo, but for symptomatic relief, we have more success with Iberogast than we have with Atrantil for symptoms. Is low stomach acid a real thing, and can it contribute to Sibo? Low stomach acid is certainly a real thing when you've been on a proton pump inhibitor where you have low or no stomach acid. In somebody who has not been, there are other drugs that can do it too, but in somebody who has not had their stomach acid pharmaceutically altered, can you have sort of decreased activity of the hydrogen potassium ATPase pump that produces stomach acid? You can. Can it contribute to Sibo? Absolutely. Because we know that, again, achlorhydria, absence of stomach acid, pharmaceutically induced, usually from proton pump inhibitors, is a major risk factor for Sibo. And we talked about that study from gut from our GI journal Gut that showed incredible changes in the tax of 20% of patients, and they concluded that long-term PPI use was as deleterious, if not worse, than antibiotic use. So we know stomach acid can contribute to Sibo. I am not in the habit of routinely recommending that patients have betaine, hydrochloric acid, or other forms of acid. If patients come in and say, you know, I have a swig of apple cider vinegar every morning and I feel great, I'm all for it. If you feel great, I don't think it's doing anything terrible. But I also think in the average person with Sibo, I'm not sure that it is, in my experience, it's not been, again, one of these slam dunk things. There were 2 questions on testing, which was the last topic, but the last webinar, in the last 2 minutes, I want to just address them. The Smart Gut test. So that's a test that's put out by Microbiome, and I told you that I'm on the medical advisory board, at least until June, for the company. And again, I just have to tell you what I really think, which is I really don't think it's a helpful test. It's a test that I think is a little bit misleading because if you're familiar with it, it gives you all these conditions like inflammatory bowel disease and diabetes and all these different things. And then it says, you know, associated, not associated with all these different bacteria. And in very small print at the top of the test, it says this test is not intended to diagnose, treat, cure any condition, and that these conditions should all be diagnosed clinically by your healthcare professional or something to that extent. But the way the information is presented, not just to the layperson, but to a medical professional, it certainly looks like what they're saying is you have this or you don't have that, and, you know, Akkermansia and all the different bacteria. And it's sort of a form of data mining, right? So there's studies that show this bacteria can be associated with this disorder. But again, these disorders are complex: genetics, environmental triggers, immune system. The idea that a bacteria causes a disease is just not really how it works when we're talking about these autoimmune diseases. And it's certainly not, oh, these 2 bacteria are associated. If you have them, therefore you have IBS or IBD or anything else. So I actually like their old test better, the Explorer, the Gut Explorer, and we were one of the beta test sites for Smart Gut. So we did a tremendous amount of those tests. It's supposed to also look for pathogens, and I have to say I did not find it helpful. The next question, can 16S RNA sequencing, so essentially think of that as microbiome sequencing, help quantify the degree of dysbiosis and or progress when trying to rewild the microbiome? And this was a longer question with a very good prelude saying, I completely agree that, you know, we can't, this stuff is in its infancy in terms of testing, but would you also agree perhaps that these tests can be useful in terms of advancing the science and helping people to think more about the microbiome? And I completely agree. I think that if we didn't have, everything has to start somewhere, right? So all testing starts from a very rudimentary basic level. And over time, as the data grows and the understanding grows and we have large databases of information, we're able to piece it together and learn more. So I really applaud these companies that, and people like Jessica Richman, who's the co-founder of Microbiome, who figured out how to do this in a way that, again, can empower the citizen scientist. But what I have to really advise against is trying to use it in a way that we really, it can't be used in, trying to say, well, if you are low in this, then you need to take this supplement and it's going to fix it and all is well, that we are not there. And I think I said that in reference to another question of somebody who was trying to see this sort of result basis for what they were doing with diet and probiotics in their microbiome sequencing. So can it quantify the degree of dysbiosis? It cannot, in my experience. Where we are with the testing at this point, it cannot. That's a clinical quantification. The breath testing cannot quantify it either, and or progress in trying to rewild. It really is a very low-tech assessment in terms of signs and symptoms. I do not feel that the testing, where it is now, can tell you you're there or you're on the right path. But I do believe that sitting down and talking to somebody about their symptoms and maybe doing a good physical exam can help you figure that out. So again, I always feel like I'm a little bit the bearer of bad news with this stuff, and I try to make it sexier than just eat more vegetables. I don't know that I always succeed, but I think the most important thing, I hope that I have given you for you, whether you are a patient or practitioner out there, I hope I have given you a sense of really how complex this is and sometimes how frustrating it is. People come in, they're really in a lot of distress. They've seen a lot of doctors. They think you have the cure. I don't. I have some advice and sometimes some solutions, and when things work, I'm so happy. Somebody came in the other day and said, I did the green smoothies twice a day for a week. Hadn't even started the VSL, and I felt better than I'd felt in 10 years, but then things fell apart and she wasn't doing the green smoothies anymore. But you know, when people come in telling me that they feel better, whether it's a probiotic or the diet or something we got rid of or whatever it was, it just makes my day. I feel so happy, but there are lots of times when the progress is slow or there's no progress, or rarely there's backward movement. Fortunately, that's not so common. But it's so important that we all share with each other, and we all help patients. We support them emotionally, and we don't recommend crazy things, and that we do things with people's best interests at heart. And when we don't know, we say we don't know. I think that's also important. So again, I'll stop here, but thank you so much for sharing your time. We would love feedback. You're going to be getting a little survey. I promise it won't take more than a minute to fill out, and give us your honest feedback. We really appreciate it, and I hope to meet many of you in person one day. Take care.